Thanks everybody for joining. We're going to talk a little bit about alcohol use disorder today, specifically briefly about assessment and a little bit about pharmacotherapy based on the 2018 American Psychiatric Association guidelines. Next slide, please. All right, so I don't have any conflicts of interest to disclose. Next. All right, so we're going to cover two main take-home points today. First, medications are effective for treating alcohol use disorder, and they really help people reduce their drinking. And specifically, it's for people with moderate to severe alcohol use disorder. And secondly, medications can be combined with other therapeutic approaches. Next. Briefly, what's alcohol use disorder? This is like any other substance use disorder. It means there's a problematic pattern of alcohol use leading to clinically significant impairment or distress, as manifested by having at least two of the following symptoms occurring within a 12-month period. And on this slide, we list all of the standard substance use disorder symptoms that you could see with any substance. If you have 2 or 3, you have a mild disorder. 4 or 5, it's moderate, and 6 or more, it's deemed severe. Next slide. I want to remind people that alcohol has substantial impacts on physical health. This slide depicts the various kinds of problems that occur if people drink regularly over 20 to 30 years. And the level of drinking required to cause these kinds of problems are depicted here. For men, it's 14 drinks per week. For women, it's 7 or more drinks per week. Now, you may think that's not very much, but the point I want to get across is you really need to think about if people are drinking regularly at this amount, they're going to have some negative consequences, and that's important to know. Now, in primary care, we see a lot of people who have alcohol use disorder. Between 1/5 and 1/3 of folks seen in primary care will have an alcohol use disorder. Next slide. So you can screen really simply with a single question. You sometimes drink beer, wine, or hard liquor, and if a person says yes, you ask them about whether they've had a single day of heavy drinking in the last year. For men, it's 5 drinks in a day, and for women, it's 4 drinks a day. If they say yes to that question, you want to proceed and actually evaluate them for whether or not they have an alcohol use disorder. When you do that, it's really important to have a non-judgmental style. People are very sensitive about stigma regarding alcohol and substance use, and they won't tell you the truth if they think you're going to judge them negatively. So it's important to have an open and non-judgmental style. We want to know about frequency and quantity of alcohol use, biomarkers, and there's a slide about that later that you can look at if you like. I want to ask about other substances too, because comorbidity is common, and also about psychiatric comorbidities, because those are also very common among people with alcohol use disorder. Next slide. The next step is to work with people to determine their treatment goals, and that will help you figure out what to do next. You want to provide education about the potential harm of alcohol and the value of harm reduction or abstinence. So you'll want to elicit patients' preferences and motivation for their goals. Do they want to reduce their drinking? Do they want to avoid drinking in hazardous situations? Or do they want to stop drinking altogether? Any of those is a reasonable goal to begin with. As you're working with people to determine goals, keep in mind this really helps form a therapeutic alliance that you can use as you work together going forward. It helps provide a structure for shared decision-making for choosing treatment. And when you're determining goals with people, you want to be thinking about whether there are legal obligations related to alcohol, such as a DWI. Are there work and home responsibilities that need to be addressed? Is there any risk to self or others? And that will help you figure out what to do going forward. Next slide. As you develop your treatment plan, once a person's goals are clear, you can start either with a behavioral intervention, such as cognitive behavioral therapy, or a pharmacological intervention. After you try one of those, if it's not effective, you can consider combining them and using both. In addition, everybody can benefit from self-help, so you want to help people become aware of their options for Alcoholics Anonymous and help them get engaged with it, because the research suggests that people who engage and stick with Alcoholics Anonymous are going to do better over time. You also really want to reach out and engage with people's natural supports, their family, their spouse, their children, whoever's involved in their lives. Provide education and get everybody on the same page so that you're all pulling in the same direction as you're working with a person with alcohol use disorder. Next slide. So what are our pharmacotherapy options? Well, first, I want to let you know that pharmacotherapy focuses on altering the reinforcing effects of alcohol use. It is not a magic pill. People do not magically stop drinking when they start taking the pill, but it does, by altering the reinforcing effects, as people continue to drink, it will be less rewarding and they drink less over time. That's how most of them work, and we'll talk about some of the specific ones today. We think pharmacotherapy is best for people with moderate to severe alcohol use disorder and heavy drinking. So if a person just has a mild disorder, pharmacotherapy is probably not for them. You want to use this for people who have heavy use. They may have ongoing risk for consequences of use. They're motivated to change. People have to try to change their alcohol use in order for these medications to be helpful. And this is for people who prefer a pill over a psychosocial intervention. And people need to not have any medical contraindications for the drug. And we'll talk about those. Next slide. This slide shows all the medication options for which there's reasonable research evidence supporting its use. The ones in bold are FDA approved for treatment of alcohol use disorder, and we will talk about them today. The other ones, I included slides with information about each of these, and you can look at those after our sessions today if you like. Next slide. Let's start with naltrexone. This is really a great first-line option. This is a medication that works through blockade of the mu-opioid receptors. The idea here is when a person drinks alcohol, part of the neurologic pathway through which people get reward from alcohol involves mu-opioid receptors. So if you block them, you block the reinforcing effects of alcohol. Clinical trials have found that this medicine seems to help people compared to placebo, and it tends to work best among men who drink heavily. It can be initiated while people are still drinking, which is quite advantageous. However, it can't be used among people who need to take opioids. For example, if somebody has an opioid use disorder and is on opioid replacement therapy, this is not a medicine for them. Or if somebody has a chronic pain condition and needs to use opioids, not a good option. It's simple to use. It's once a day, either 1 or 2 tablets. Also, there is a long-acting injectable form called Vivitrol, given once a month. That takes the decision to take meds every day off the table, and it's quite easy for people. Next slide. There are mild side effects that you want to educate people about and watch for. Nausea is the main one. Also, be aware that among a very small proportion of people, they can experience liver irritation and have an increase in LFTs. So you need to check liver function tests prior to initiating this medication, and then you need to check it again in a few months to monitor for that. Because of that potential side effect, you want to avoid this medication for people who have alcoholic hepatitis or liver failure. You also, as I said before, want to avoid this medication for people using opioids. However, this is a medication that can be used for people who have opioid use disorder once they become abstinent. If you initiate while people are still using opioids, it will precipitate withdrawal and people will not be happy. All right, next slide. Acamprosate is the second first-line option to consider. This medication works differently. It's thought to modulate glutamate neurotransmission. This means that it settles down the glutamatergic hyperactivity that happens when people are in alcohol withdrawal and in the long-term sort of post-alcohol withdrawal syndrome. So this is a medicine that we use after people have achieved abstinence. It's not as easy to use as naltrexone. It's a 3 times a day dose. There's some mild side effects, as you can see there, also gastrointestinal. This medication is not metabolized by the liver, so you can use it for people who have alcoholic hepatitis or liver failure, so that's a nice option there. It's excreted through the kidneys, so if people have problems with kidney function or kidney failure, you have to attend to that. This is a great choice for people who need to be taking opioids or who have opioid use disorder and are on replacement therapy. The research also just suggests that people who respond to this medicine are a little different from those who respond to naltrexone. This medicine seems to work a little bit better with women, people who have anxiety, people who have a negative family history for substance use disorders. So there are contrasting options here. Next slide. The third med I'm going to talk about today is disulfiram or Antabuse. This medicine's been around for a long, long time. It works differently than the other two meds. What this medicine does is it inhibits the breakdown of alcohol by stopping the aldehyde dehydrogenase enzyme. So it prevents the metabolism of acetaldehyde. And acetaldehyde is toxic, so that builds up in your system and makes you feel sick. And the symptoms people get are on the right side of the slide: sweating, headache, changes in blood pressure, sympathetic overactivity. People feel quite ill if they drink while they take this medicine. So you teach them about this and help them understand that this is a medicine that will help them deter themselves from drinking when they have the urge to drink. Often people, while they're on this medication, will try a little alcohol and test it out and have a reaction, and then they'll learn, okay, it does work. This medicine also works for people who have cocaine use disorder. So people who have combined disorders, this would be helpful for. It's a great option for those who are seeking abstinence, but they don't want to try the other things or the other things didn't work for them. If they have a family member or a friend who can monitor their use of this medicine, it's likely to work better. Next slide. It's easy to use. It's a single daily dose. You start out at 500 milligrams, and after 2 weeks, you tend to lower it for most people. It's got mild side effects. It's best to use for people whose goal is complete abstinence and those who can have a family member monitor their use and work with them together on their abstinence. Next slide. So in summary, medicines are effective for reducing drinking in people with moderate to severe alcohol use disorder, and they can be combined with other approaches. So I will stop now and put myself on mute for a bit. We can have some time to talk about cases. And just a reminder, there's other slides that describe what we talked about today in more detail. Take a look at those after our session today. There's a lot of good information there. Thanks so much.